Up. So when you have your real times, when we're doing the foot or the ankle, I want you in a seated chair. In the training room we have stools, and they're going to be in a short sit, so they're going to be with their leg is off the edge like this, so that we can do everything we need to do, and then you can just rest their heel on your leg. So if we look at the board up there, your real time, you guys should have this. Chief complaint, onset, and mechanism is basically given to you when we're doing these real times. So we said that in order to do a really good evaluation, we've got to know the onset and the mechanism, right? So we need to know, did they plantar flex? Did they axial compression? What was it that they did in order to bring this pain upon? A lot of times, quite honestly, they're not going to remember. They're going to say, I really don't know. And the other key question in doing that is, was there a pop snap? I want to know, was there a defining moment, an acute pop snap? So chief complaint, it's her right foot, onset, acute, defining moment, pop snap, and what was that mechanism? Did she land like this? Did she turn her foot in like this? Did she turn her foot out like that? As best you can tell, did someone step on top? As best we can tell from mechanism, that's going to be given to you. So when you come in, you're going to explain to the class. The first thing that I'm going to do is I'm going to look for any obvious deformities or swelling. That's a big thing that you want to look for. Looking straight down on the foot. The next thing is we're going to go straight from that to our palpations. And Tito just showed us how to find that navicular bone. When we're doing the foot specific, I want you guys to have them dorsiflex, pull back and relax, and you're going to find that navicular bone right there. So I'm on the navicular bone. Remember, we called that in lecture, that's my end spot. And then I'm going to move around to the navicular tubercle right there. So it wraps around all the way to there. All right? There's my navicular tubercle. So just distal to that's going to be my what? First cuneiform, and then distal to that's going to be? The first metatarsal, the base of the first metatarsal. So I've got navicular, cuneiform, so my first, second, third cuneiforms. So we went from navicular to the first, second, and third cuneiforms. I can bring my hand in here. I'm palpating across. What is this joint here? That's my Liz Frank. My first metatarsal, my second metatarsal, my third line up with my first, my second, and my third cuneiform. So that is my Liz Frank joint going across. So while I'm palpating from navicular to first, second, and third, I'm going to palpate any tenderness, any pain with my movement here, tarsometatarsal glide, while I do my palpations going across. I come to the cuboid bone out here, the lateralmost tarsal bone. Then I'm down to the base of the fifth. I'm palpating on the fifth. How did I tell you if you had any question on the fifth? I would have them evert, and we've got the peroneus brevis comes and hooks in right there. I go from the base of my fifth all the way out to my fifth MTP joint. From my fifth MTP, I move to my fourth MTP, to my third MTP, and to my second MTP. While I'm doing that, I can provide long bone compression, any pain back up the shaft of the bone, okay? So I did 2 of my specific tests while I was doing my palpations. Make sense? I did my first, second, and third cuneiform while I'm also doing my test, the tarsometatarsal glide for the Liz Frank. And then when I'm palpating my metatarsal heads, I can also do my long bone compression for pain that's coming back up. If they have dorsal aspect pain, in other words, we're palpating the heads, and you can also catch the shaft of each one of those bones. Then I'm going to move to my first MTP joint. This is my first MTP joint. How did I tell you guys to find it? Flex and extend. You can feel you're in the joint space. My thumb is going to be on what? Sesamoid bones, and what else lives right there? The plantar plate. That's my plantar plate. So while I'm palpating on that particular bone right there, or on that particular joint right there, now I can move into, if you see right there, when you, I don't have you go into the particular glides and all that. We're going to do that next. So just palpate this first MTP joint, all right? You can go on this is the medial side, the lateral side, palpate in that plantar plate. Then I want you to slide your hand down here for plantar fascia and Achilles, okay, in your palpations, okay? That's the sequence that I want. Now, I understand that if your athlete came in and they're complaining of turf toe injury, we're probably not going to go through all of this, but this is how I want you guys to learn going through the real-time foot. Okay, so you're hitting a little bit of everything. Okay, now, so after we've finished our palpations, then what do? Active range of motion, right? So I just simply want her to curl her toes down. I'm catching the great toe and the other digits, and then she's going to extend them out. So that was my active range of motion. And then my MMT, I really want you to focus in on extensor hallucis longus, so she's going to pull back. Flexor hallucis longus, pull your toe down, and then don't let me pull it up. And remember to palpate back up through here. Remember, we can get some pain, kind of looks like arch pain down through there. All right, so palpate. If you have to palpate on your lab exam, flexor hallucis longus, have them flex, you're not going to feel it right here, but you will. It wraps around that medial malleolus, right? Comes right underneath there. So we're going to palpate back down to there. Okay? So that's my MMT. Now my passive range of motion, I'm going to take them all the way into extension. How many degrees of extension would you like to see? 70. In your test, it's probably going to say what? 75 to 85 degrees. Some people can get that far back. But push them into passive extension. That's a test for us because we're looking at see if we can recreate pain or an issue going on with the plantar plate. Once I've done that, once I've gone from passive great toe extension, I'm going to go right into my glide. So my glide, I have to come here just like I did up here. I'm going to stabilize proximal and then distal, and then it's just an AP glide. You feel that? Crunch, crunch, crunch. Okay, so I'm just going to do an AP glide on that. Then I can stabilize here, and I can do a varus and a valgus. Varus, valgus. See what I'm doing there? Okay? So you go from passive great toe extension into your AP glide into your valgus and varus. Okay? There's only two other exams that we're doing with this. So we did a tarsal-metatarsal glide while we did our palpations. We did long bone compression. Then we got passive range of motion, great toe extension, see if there's any pain in end range. AP glide, valgus varus. Now there's the neuroma, right? Well, we already palpated through here, but we're going to come back and find out, is there any pain in this web space here? So between the third and the fourth, and the fourth and the fifth, but most of the time you're going to look at all of them. So first to second, second to third, third to fourth, that's typically where we're going to see the neuroma, right? Then we're going to take our hand and we're going to squeeze the toe box, take our thumb, and push up into the bottom of the foot. So squeezing the toe box and squeezing or pushing up in is similar to the way they usually get the neuromas, right? So a lot of ladies will wear, really fashionable shoes and the toe box is nice and tight, right? Could be from other things, but typically that's where you see that. And so the toe box is too tight, so we're just recreating that, pinching it, and then pushing up into the foot there, okay? Looking for the neuroma. The last thing that you're gonna do with the testing of this is we're gonna have you lay on your stomach with your legs off the end. We're gonna do the Thompson test, because we're gonna check for the Achilles. So we're just gonna simply come in here and we're gonna push and see if she plantar flexes, okay? Now, I will tell you, she doesn't have a big plantar flexion there, right? It's not really pronounced. Go ahead and flip around and leg off again. But I did have an athlete that tore their Achilles, and when you squeeze the calf, you should see it plantar flex, and that would give you a quote-unquote negative test. But I had an athlete, their mechanism, it just screamed that they had torn their Achilles. Felt like someone kicked them in the back of the leg, the whole deal. That's typical. So I put him on his stomach and I squeezed his calf and he's still plantar flexed. But, I'm sorry, go ahead and lay down one more time for me.
Was it like a full hair?
I can't remember exactly what the MR said or anything like that. I don't remember. But you do have a lot of muscles down here, so it might have been the extent as to the reason why. I can't even remember if he had it repaired. But what you can do also is whenever you squeeze, you're going to look at their Achilles tendon, because his was nice and thick on one side, swollen, and the other one was nice and thin. Okay, but whenever I squeezed him, he's still plantar flexed. So I might have been getting some of the soleus, I might have been getting something else that was actually allowing him to plantar flex, or he had a partial thickness tear versus some full thickness tear. So he might have had just some, low grade tear versus a large rupture. Okay, so I can't remember exactly how that all went down, but you could definitely look at the integrity of one side to the other and tell that he had an injury to his Achilles. His mechanism, everything he explained in his mechanism, his chief complaint, and then you look, he was sore there, he was more swollen on one side to the other, but when I did the test, go ahead and flip around. Now remember what I said, and the reason why we do the EBP at the end of the semesters, we'll do a number of these exams, they're gonna be more sensitive than specific, okay? And if we got a sensitivity rating or a specificity rating of a 75, that's pretty good. So you can see they're just not, it's not the be all end all, these clinical exams. You want to match your clinical exam to your diagnostic exams. Okay, so that got us all the way to the neuro part and to the vascular part. So simply with the foot, I just want to ask them, are they getting any tingling and numbness? If it was someone complaining of that in Morton's neuroma, they're pretty much going to pinpoint in that web space, okay? Seldom in the foot do we get a lot of things like we would get up into the upper extremity as far as ulnar nerve, neuropathies and stuff like that. But in the foot, we do have Tunnels where we can tap over there, different ones. But so for the neuro section of this, the main thing we want to find out is, are they having any tingling and numbness? Remember, we did great toe extension, so we'd already done some of the myotome part of this. But tingling and numbness is the main thing. And what I'm basically saying is I don't want you to go all the way through the lower extremity neuro for the foot. But I do want you to tap here for the posterior tibial nerve. And so the posterior tibial nerve, and then you already did the Mulder's test right there. Okay, for my distal pulse, I have them pull the toe back, and I find that extensor hallucis longus, right? And then relax, and I go just lateral to that, and I can find the pulse. Okay, so you're gonna find dorsal pedal pulse. All right, and then whenever you get done with that, you throw your hands up like this. Okay, so what you're gonna do is you're gonna, when you come in, I want you to go through that whole thing. So first thing, I'll say chief complaint, onset, mechanism, and given to you, ready, go. And you're gonna say first, I'm looking for obvious deformity and swelling. You're gonna go straight from inspection to palpation. So we went from the navicular, first, second, third cuneiform, tarso-metatarsal glide, move over to the cuboid bone, I move over to the base of the fifth, I palpate all the way out to the base of the fifth, the fourth, the third, the second. Along with that, I can do the long bone compression and palpate up the shaft of the bone for any pain on the shaft of 2 through 4. And then I'm going to palpate my plantar plate, my MTP joint, my plantar plate. And then I'm going to palpate plantar fascia. And then I'm going to palpate their Achilles, which we can take a better look at that Achilles when we have them lying prone. Okay? From there, they're going to bring their toes up. They're going to squeeze their toes down, active range of motion. And then MMT, pull toe up, pull toe down, MMT. Passive range of motion, I've got them here. I'm just going to take them into end range right here. See if there's any pain with that. Then I can rest them right here. I can come in here and do my AP glide. I can do my valgus varus. Okay, and that's pretty much taking care of my big toe, right? Then after I get through with those, I'm going to do the Mulder's test, and then I'm going to do the Thompson test. So I come in here and I squeeze, and then I would have her lie down. I squeeze calf. I can take a look at that a little bit more. Any tingling and numbness, and then I check distal pulse. Okay, that's how I want you going through the real time. That's to be a little bit quicker. Okay, all right.